Good evening, friends. A very good evening to those in India and in the United States. It's a very good morning to all of you. Let us begin the first on this series of COVID impressions, the webinar to talk about our impressions of the COVID pandemic. And I'm delighted to welcome all of you on this panel, as well as the attendees who have joined us on this warm summer evening of May in India, and a nice, cool, breezy morning, probably in Baltimore and the United States of America. So to begin the webinar, I'm just going to play a small welcome message by our director at the hospital, Dr. Sunil Kumar, who is the medical director, and here he goes.
Hello friends, I Dr. Sunil Kumar, the medical director of GTB Hospital and CMS. Welcome you all to the webinar, COVID Impressions, being held on May 27th between 6 and 7 p.m. Indian Standard Time. This webinar has been arranged by the local experts from GTB Hospital and UCMS in close cooperation with national experts from Johns Hopkins Bloomberg School of Public Health. As you all know, Delhi is going through an epidemic of COVID-19 infection. Therefore, local situation will impact the global policy. There is no doubt about it. And how is it going to impact the global policy? That's what the experts will discuss. The wait for the vaccine has been long, but we need to know what will be the impact of immunization by this vaccine, and how do we mitigate the community impact. Further, as far as the local preparedness is concerned, we need to know vis-a-vis the global experience how well we are prepared. These will be the topics which will be discussed. These are important topics. These will be discussed by the panelists. Please feel free to discuss and interact with the experts. That will be the great learning experience, I trust, and therefore I welcome you once again and thank the organizers for organizing this webinar of great importance with the help of international experts and the local experts. Thank you all. I'm very sure you will enjoy the interaction and discussion.
So that was Professor Sunil Kumar, who is the medical director of Guru Tegh Bahadur Hospital and himself a professor of surgery. From here, I move on into another welcome message by our principal, Professor A.K. Jain, who's the principal of University College of Medical Sciences and also himself a professor of orthopedics. So Dr. A.K. Jain has also recorded his message, which I'm sharing with you.
Dear learned speakers and friends, coronavirus has brought whole human race on its heel. And now we have come to realize that world order will be decided by tiny particles, tiny microbes, viruses, and not by the Iranian dictators, nor by the mighty bombs and Star Wars. And that is that can be appreciated, that more lives have lost globally in last 3 months than all other events put together. The impact of COVID-19 and coronavirus will be such that we are going to remember the time as before corona, that is BC, and after corona, that AC and not the AD. And this impact is just not going to be the impact on life, but this impact is going to affect socially, emotionally, psychologically, financially, and whole world's economy is going to suffer. Well, the last pandemic recorded was in 1970s, that is Spanish flu, and it brought huge devastation to the world, and so much so that 50 to 100 million lives were lost globally, and 12 to 18 millions in India alone. And this Spanish flu lived its natural history, and gradually its intensity was reduced. Well, I'm sure COVID-19 has spread faster in comparison to Spanish flu because of huge movement across the continents, across the countries, across the city by human race. And that is why this spread is faster. But I'm sure in spite of this fast spread. We all know that intervention by our medical experts, by our researcher, by our clinician, this is not going to have the same longer span of its natural history. It will be halted somewhere, anytime. And in that efforts, our researcher community globally is putting a lot of efforts in developing vaccines, a lot of efforts in developing some drugs so that this disease could be brought to its control. I'm sure we have our understanding better in mitigating the community effect and taking good use so that its spread, its impact on the community could be minimized. So these 5 topics, they are very useful to us to understand, and I'm sure after the presentation by these 5 learned speakers, we will be wiser, and I'm sure we'll add, and I'm eagerly waiting to listen to them, and I thank you very much indeed, and say my best of luck.
So let's go on from here. So myself, let me introduce myself. I'm an associate professor of medicine at the University College of Medical Sciences in Delhi. My name is Dr. Rajesh Goyal, and my colleague on this panel who will be moderating is Dr. Amir Maroof Khan, who's an associate professor of the Department of Community Medicine at UCMS Delhi itself. I will be introducing the panel to you as we move in, but before that, we will just have a short, quick poll. And this poll I'm opening up to you now. And this poll is simple. It's coming on your screen, and you will be able to answer this poll yourself. We have less severe disease in India than in the United States because you could select any one of the following reasons. And in your opinion, what do you think is the best possible reason for this pandemic to be less severe in India than in the United States? You can choose wisely. So I will be closing the poll in another 10 seconds, and I see quite a few of you have already responded. We will be having the poll on for another 2 seconds, and then we are winding up the poll. So I'm going to share the poll results with you, and it's interesting to note that almost half, nearly half of us feel that it's because our government took effective measures which were timely. 30% feel that it's the immunity which is helping us, and we Indians have high immunity because we can live with practically anything. And there is a little, some of us who also feel that probably it's the virus which is milder, or the hot temperature is having its effect. Thank you so much. And moving on ahead from here, I now will open the panel to give an opening remark, an introductory remark in the beginning. It will be a short opening remark, and then we will go into the main presentations. I invite Professor Arun Sharma for the first opening remark. Dr. Sharma is a professor in the Department of Community Medicine at the University College of Medical Sciences, and he was a Humphrey Fellow and an alumnus of Johns Hopkins University School of Public Health, where he studied epidemiology, biostatistics, urban health, and geographical information systems. Dr. Sharma.
Good afternoon to all the listeners and participants from India, and a very good morning to participants from USA and my co-panelists. The opening remark on the basis of what I have been asked to talk about, mitigation of community impact. I want to say that this is one unique condition which has happened in a century, when of course, at the center of this entire phenomenon is a human life. But this disease, COVID-19, has touched upon every geographical corner of the planet, and it has impacted every conceivable sphere of human life, be it their health, or their social life, economic life, or mental health. Every aspect has been impacted on one side. And on the other side, we are in a state or condition where we are primarily taking it as a challenge and not able to find ready-made answers. Though we are only 4 months into the disease process, but our understanding of the natural history, our ability to find a vaccine or a treatment are eluding us to a large extent. So it's a bigger challenge, and it is as much as a challenge for the society and the community as much it is for the medical fraternity or the governments the world over. So we really need to ponder over the issues that are related to the community impact and question how to mitigate them. I will stop at that on my 1 minute, and then I will come back and share with you the details. Thank you.
Thank you, Dr. Sharma. I'm missing Dr. Yadav, probably some due to technological issues, but we will move on. Professor Shukla Das is our next panelist, who's a professor of microbiology, again at the University College of Medical Sciences in Delhi. And I would invite Dr. Das to kindly put forward her opening remarks and introductory comments. Dr. Das.
Okay, good evening to all the panelists. Am I audible? Yeah, Dr. Ashish?
Yes.
Okay, so good evening to the panelists and to the audience, and a big thank you to Dr. Ashish for this webinar. And so my topic is on wait for a vaccine, and as rightly said by Dr. Sharma, that we are looking for a strong, robust sterilizing immunity, and for that pandemic to bring the pandemic to a stop. So are we really being realistic to have a vaccine in a very short duration, or are we waiting for the peak to fall its own, have its own natural fall, and then waiting for the naive population to develop a herd immunity? So I'll go back to my slides and my talk when I am asked to. So with this remark, I thank Dr. Ashish for introducing me to the panelists and the audience.
Thank you, Dr. Das. And we move on to our next panelist, Dr. Anita Shah. Dr. Anita is the Director of Child Health at the International Vaccine Access Center, which is more popularly known as IVAC at the Johns Hopkins School of Public Health in Baltimore, USA. Dr. Shah, your remarks.
Good evening, good afternoon to all of you, and good morning. It's a pleasure to be here, and I just want to thank Dr. Ashish for inviting me here and also having this whole panel discussion. And I want to echo Dr. Arun Sharma and Dr. Shukla Das about what they were saying about the current situation. There's really so much that we don't know yet. It's an evolving situation. There's much happening because of COVID and also the indirect effects of COVID, some of which I will be talking about. But it's really good to be here together, and I'm looking forward to a good interactive discussion. So thank you again.
Thank you, Dr. Anita Shah. And I will now move on to Professor Bollinger. So Dr. Bob Bollinger is the Raj and Kamla Gupta Professor of Infectious Disease. He is a professor of medicine, public health, and nursing. He's also the director for the Center of Clinical Global Health Education. He's the associate director of medicine at the Center of Global Health, and he's at the Johns Hopkins University School of Medicine. Professor Bollinger, all yours.
Thank you very much, Ashish. It's a great pleasure to be able to participate in this webinar, and thank you again, and good evening to everyone in India. I was asked to make a few remarks about lessons learned locally and how they can be applied globally. So I will be talking a bit about what we've learned here in the United States that might be of help to others in India as you're thinking about this epidemic in your own community. But as I was thinking about this, I was reminiscing a bit, because I had my education in public health and infectious disease actually began not at Hopkins, but in India in 1979. So I've had the great privilege of being able to work with colleagues in India for over 40 years in infectious disease and public health. And my lessons learned were local lessons learned in rural Bihar, in Maharashtra, and other places where I've worked for many years. And so I think we're going to learn, we learn a lot from each other, and I look forward to being able to share and hear and continue to learn from you.
Thank you. Thank you, Dr. Bollinger. And moving on from here into the presentations per se. Let's begin first listening to Dr. Sharma. And Dr. Amir, my colleague, has now joined us, and I would invite Dr. Amir to kindly introduce Professor Arun Sharma once again with a personal touch. He works in the same department with Dr. Sharma, and I'm sure he would be able to do a better job than I did in the last minute. Amir?
Hello, am I audible, Dr. Ashish?
Absolutely, loud and clear.
Okay, thank you. Sorry, I joined, was some technical glitches. I joined a little bit late. It's a pleasure to introduce my teacher and my senior, Dr. Arun Sharma, who is to start with the first session. He is a professor in community medicine in our University College of Medical Sciences. And he has received the prestigious Hubert Humphrey Fellowship to study epidemiology, biostatistics, and mental health at Johns Hopkins School of Public Health in 2004-05, and awarded various traveling fellowships by WHO, Rockefeller Scholarship, and also to the University of Illinois. And he is doing a great job at present with respect to the pollution control, especially environmental health, and with the GIS mapping, which is new in India and also for the world. So this is where right now, and he's an epidemiologist par excellence. We all look up to him for epidemiology and biostatistics. So with regards to understanding of data, interpretation of data, and using data appropriately, I think he is one of the best. So I would like to invite here Dr. Arun Sharma to go ahead with the session. Yeah, yes, sir.
Professor Sharma.
Thank you, Amir, for that extended introduction. And I'm really proud of the fact that you called me an epidemiologist, and I owe it to people like Dr. Bollinger, who is here with me in the panel, along with some great teachers I had an opportunity to learn from during my Humphrey year at Hopkins. And it's really a very proud association, and it's once again a pleasure to be with them on the same platform. And I start my presentation by talking about the important issue of community impact of COVID-19. When we say community impact, as in my beginning remark, I said that every aspect of human life has been impacted. We have to be very careful in addressing the issues that are at hand, because we are absolutely in uncharted territories, and there are no guiding lines at this moment how to tackle the situation. Every day a new situation is emerging, but fortunately you will see through my presentations that we have certain positive outcomes also, in spite of being in the middle of a novel pandemic. I will start with talking about the adverse health impacts on the community. What the disease itself is doing is something that we have been talking about, but we need to address that due to COVID-19, the way it has suddenly impacted all over the world at the global level as well as at the local level, the communities are struggling with the problems that are coexisting besides COVID-19 in terms of health. For example, difficulty in accessing emergency healthcare services due to diversion of resources. For example, patients who require dialysis almost on every day or alternate day basis on ambulatory conditions, people who need help from the coronary care units or intensive care units due to acute conditions, or emergency room visits primarily for exaggeration of bronchial asthma or COPD attacks, or because of the road traffic injuries, or as an impact of domestic violence, they are finding it extremely difficult to access the emergency health care, particularly for two reasons. Number one, because of the existing lockdown, access to those services is not available as the transports are closed, or the resources at the hospital are diverted to take care of the COVID-related emergencies than these patients. On the second side, the planned treatments like surgeries or other intervention procedures which people have been waiting for to the month of March, April, and May, they are being indefinitely and infinitely postponed for no fault of the patient themselves, and that is increasing their agony. That probably is adding to the burden of diseases besides COVID-19 that will have a serious impact on the health of the communities per se. And this is not true only for developing countries or resource-constrained countries. These problems are being faced simultaneously even by the developed countries. On the third aspect, which I'm sure Dr. Anita is going to talk in detail, but I thought need to touch upon, that services like antenatal care, the routine immunization program, and the delivery of other national health programs are on the back burner, and the benefits that might have been attained in the last 10 or 15 years by rolling out several national health programs will take a backseat, or probably there will be a reverse rolling down of those gains that have been made in these areas, and we don't know when will we get an opportunity to start again. Since we have to look at the mitigation efforts, I will immediately point out that it's required that there should be appropriate allocation of resources so that other health conditions are not neglected. We have to think about parallelly providing these services and not put them on a back burner. The other adverse effect is on the mental health. The mental health problem is likely to be a hidden problem, as it is mental health is a hidden problem. But at the same time, we are getting information from different parts of the country that there has been an increase in the suicide rates, there have been increase in domestic violence, and anecdotal examples of depression and anxiety I can share with you, that several of my colleagues from the non-medical fraternity who are engaged in different services or in different jobs definitely call up or inquire through WhatsApp or other type of social media, the doctor, what's happening? How long we have to be confined to our homes? Doctor, how serious it's going to be? Doctor, when are we going to find a medicine? Doctor, when are we going to find a vaccine? These are the questions which basically are asked that only reflect that the anxiety and the mental restlessness that the people are suffering because of this problem. And certainly in the long term, that can result into prolonged mental illnesses. And added to that, I'm afraid to share with you, again, I will talk about it, that the fear psychosis that COVID-19 has brought to the common man on the street, that is something alarming. Not ability to think in a balanced way, not being able to sustain the anxiety or the stress for a long term is really resulting into fear psychosis like situations. Unfortunately, to that, there are additions from the mass media as well as the social media. The only solution that I can think of mitigating this problem is in terms of providing mental services to the last man standing, even in the distant corner. But at the same time, we cannot ignore certain favorable health impacts that are happening. To share with some of those, social distancing, hand hygiene, use of masks are definitely going to be measures which will bring down incidence of acute respiratory infections, because it's a common mechanism that will prevent transmission of infectious airborne infections in particular. To that is also added the impact of lockdown in terms of reducing air pollution, ambient air pollution. There's a dramatic decrease in the air pollutant levels, air quality index improvement across the globe. More so in the developing countries where the levels were very high. We have seen that there has been a reduction of particulate matter 2.5 concentration by 60% in Delhi, which has been the most polluted city during this lockdown period. Or for that matter, other cities like Mumbai, Pune have also recorded a drastic reduction in PM 2.5 levels to the tune of 25 to 40% from the pre-lockdown levels, which is a good sign in terms of also knowing that it is possible to live and create less polluted environment, so that the diseases that are occurring because of the poor pollution levels in these large cities can also be mitigated without really compromising much with the economics and the social dimensions of it. Similarly, acute exacerbations of chronic obstructive pulmonary disease and bronchial asthma will come down because of the improved air quality and also reduction in the sources of pollutants in our breathing environment. And I also feel that staying home should reduce anxiety and stress of traveling, thus reducing acute coronary conditions, particularly in high stress life situations of people in various sectors of their economic and professional lives. Now, those favorable health impacts should be sustained for a prolonged positive outcome by promoting healthy behavior, and it should remain as a part of our life. It should become a practice of our life beyond the COVID-19 phenomenon. Another very serious impact of poor risk communication on the society is visible. The guidelines are confusing. There are multiple agencies which are trying to educate people, and that's creating more confusion than bringing clarity to what should be done and what should not be done. Ever-changing management protocols, unfortunately, are communicated to the mass media to record some. For example, whether hydroxychloroquine is the right drug for treatment. Now, as long as it is in the hands of the doctors and the medical professionals, they carry a meaning. But when through the print media or the electronic media or through the social media, when this news comes out, then every human being who's watching these items get concerned. He rushes to the pharmacy, unfortunately in developing countries where it is not much regulated, and starts buying hydroxychloroquine on his own and becomes his own doctor, which is a very serious situation, and it is only a fallout of a poor risk communication and not being controlled that what should be given as information, as the right information to the common man, differentiating it from the information that is to be consumed by the healthcare professionals or the planners or the scientists. This lack of differentiation in the modern connected, internet-based connected world throws up another challenge. And at the same time, I will also emphasize that the disproportionate emphasis on malicious intentions of the country or religious congregations, again highlighted disproportionately by the media, are causing more damage to the communication system. And as a result, people are taking their own interpretations and behaving in a manner which more looks like a mob mentality or a crowd mentality, which cannot be simply done away by giving positive messages. And to that, we are bombarded by fake news and rumors to the unsolicited and the unscrupulous sites, which are adding fuel to the fire and not helping the cause of mitigating the impact of COVID-19 on the communities. So in this condition, this poor risk communication has to be done away with. We have to make concerted efforts at the policy level, at the administration level, at the implementation level, as well as at the consumer level, to see that the right communication is transmitted to the appropriate targeted group of population, be it a small group which is more required, which is more focused in understanding the communication, or even one-to-one communication if it is required. So I put the maximum onus of mitigating the community impact on improving the risk communication measures for the society. We also have to look at that as the drama is unfolding, as the impact of the pandemic is unfolding globally in newer ways which have not been seen hitherto before, the internal migration of workforce, which is resulting, has a more geographical wider dimension of COVID-19. In order to highlight that or further emphasize, I want to share with you that in India, at present, 69% of the total cases and 73% of the active cases are only from 4 states, of which the Maharashtra, Gujarat are the bigger states, whereas Delhi being just a very small state, and it contributes to 9%. That means that 63% are being contributed by Maharashtra, Gujarat, and the southern state of Tamil Nadu, thereby meaning that the epidemic to a large extent so far is concentrated in these 4 states. But we have to take that with a pinch of salt for 2 reasons. Number one, that the testing of the disease, the surveillance mechanism is not in place in most of the states. And secondly, because of migration, where I presume, if not millions, but at least hundreds of thousands of people have started moving to their respective native places, and that primarily is targeted at the states of Uttar Pradesh, Bihar, Bengal, Odisha, and Madhya Pradesh, which are the largest states. And when this migrant community reaches there, without actually having practiced the true social distancing during the course of their migration, or without having access to the proper testing methods for availability, whether they are negative at the time of going there. And the initial results are for us to see that now cases have started appearing in the smaller cities, the town C-type and the D-type cities, and even pockets of cases are emerging from the rural area of these states. So we have to be prepared for larger number of states showing us larger number of cases, and how to deal with that is really a challenge we need to think about before the situation becomes out of proportion. Finally, I would like to say that on the other side, the community impact in terms of economic recession, the social trauma of uprooting and displacement, followed by poverty and hunger, are the challenges that will start taking monstrous shape in days to come. We are already seeing incidents of violences on the highways, where the people who have taken to walk back to their home at least hundreds of kilometers, their frustration, their anger is reflected on the violence that is being inflicted on the passing by cars that has been seen on some of the highways in eastern India, which is a very disturbing trend. And the mental and social trauma that is happening, that will require financial support as well as extensive network of counseling facility, so that the nerves can be calmed, people can be reduced from their anxiety and stress states, so that they can positively participate in mitigating the impact of the disease on the communities per se. These mitigation measures I'll tell you in the end, and the way forward I will reserve for the last concluding remarks. I would like to stop it for the time being. Thank you. Ashish, you are not audible. Your mic.
Thank you, sir. Thank you for your inputs. And from here, we would move on to our second presenter from here, Dr. Anil Yadav, who's on the panel. Dr. Yadav is the additional medical superintendent at our hospital, who's also looking after the COVID response locally at our hospital. He's also the team leader for the team which is preparing and executing the response at our hospital. Unfortunately, Dr. Yadav is not visible on the webcam, but I will be bringing on Dr. Yadav in voice. Dr. Yadav, you could unmute your mic and speak to the audience now.
Do unmute something?
Yes, you're fine. You're good. Go ahead. Yeah, just click on the, yes, go ahead. You're good now.
Okay, right. Good afternoon, everyone. I'm supposed to speak on global experiences. This pandemic is happening in almost all the countries, almost simultaneously, a few weeks here and there, maybe months here and there. So we don't have really very unambiguous lessons from other countries as to what to do. Everybody is trying something, and we do not know actually what is the best way to deal with it. There's a fine instrument, there's one blunt instrument to deal with this condition in the absence of vaccine or antiviral drugs. Fine way of dealing with this is testing people, tracing the contacts, quarantining them, and treating those who require treatment. And this requires lots of resources, and many countries are able to do this sort of fine using fine tools, like Germany and Korea and South Korea and Taiwan. So they are able to do this. India, we do not have so many resources, so we resort to blunt instrument, and that is the complete lockdown of the country, and which we have done very successfully in the initial phase. We did a very strict lockdown of the whole country, prohibiting movement of people and enforcing distance. So this blunt instrument has given us a time and it has prevented the spread of infection in initial few months and given us some time to make the preparations for this pandemic and getting our logistics and getting resources to deal with these cases. But this cannot go on. It has its own problems. So ultimately, we have to and this thing we have to use our final instruments of testing. We have to augment our testing facilities and tracing the contacts and quarantining them. These facilities have been augmented in the last few months. Now testing is more than 1 lakh tests are being done daily. So this is a massive improvement from the few months back position. So, and we have created a tiered structure of hospitals for mild, moderate, and severe cases, and those requiring ICU cares. So during these months, we have made a lot of preparations, and now we are in a better position to open up the country. For this preparedness, these various countries are following various strategies. Some are taking stringent measures like India and like China did. Others are using less stringent measures, and some are faring bad in a better way. Some are not faring so good. But it is very difficult to say which method is best because there are so many confounding factors. Income levels are different, resources are different in different countries, and whether the success of Germany, for example, is because of the strategy it has adopted or because of the pre-existing very well equipped infrastructure they have, or whether it is because of this, and whether what is the density of the population. So there are so many factors, and perhaps machine learning and artificial intelligence, deep learning algorithms may be able to tell us which factor is responsible for how much contribution to controlling the disease. During this pandemic, during my role as the main person for making arrangements in our hospital, I have realized certain challenges for the preparedness for the pandemic of this size. One is at the structural level, and one is at the mental level. At the structural level, in last many decades, we have not invested much in healthcare in India, and especially promotive and preventive healthcare. Corporate hospitals have proliferated, but they are not of much use for handling such a pandemic. And our hospitals are made in a way not to deal with such pandemics. Our hospitals wards, our corridors, they are not designed to prevent infection from positive patients to negative patients. There is hardly any way we can keep patients in our wards so that the infection doesn't spread to others. There is no concept of distance among the beds. Corridors are such everybody has to cross the same corridor. We have not been able to identify any area in the hospital where they can be isolated, separated, where infection can be prevented. Another thing is the air conditioning. Our hospitals are either not air conditioned or have central air conditioning, which cannot be used in this period. Window ACs are required, and it is not easy to install window ACs in such a short period. And our postgraduate students who are working there wearing PPE, they find it very difficult to even wear it for half an hour to 1 hour. Their sweat dribbles so much that they have to remove their gloves to let the sweat come out of their sleeves, and then wear the glove again. So that will expose them to infections. Another structural constraint is the rules we have. Our financial rules, they have been made to prevent the corruption. They have been made to prevent the wastage of government funds. So they are not known for being flexible or being resilient in a time of pandemic. So because of those harsh rules, it is difficult to move quickly. And other bottleneck is the lack of trained manpower, lack of trained tracers and contact tracers. Before this pandemic, nobody had heard of quarantining and contact tracing. That was never used. Even if it was indicated for some disease, nobody was doing it. This is the first time this is being done in a very serious manner. Another level of challenge I feel is at the mental level. At the senior leadership level, When suppose I'm a senior leader and I have to plan and prepare for the upcoming pandemic, it is raising in China and it may come to India or may not come to India. So the biggest hurdle at my point level is not the logistics, it is the uncertainty. If I make huge preparations preemptively and a huge expenditure and the pandemic doesn't come, then I look like a fool. So because there is a different level of blame for act of omission and act of commission. So everybody is afraid of making preemptive preparations. So people, last time there was a scare of SARS and it didn't come to India. So this time in the beginning, in the January month, when the pandemic was raising in China, people were afraid of making huge preparations. We were told that don't buy so much that it goes to waste. You know, last time in swine flu we bought tens of thousands of vaccine and they were wasted. So don't make so much of preparation. Just so some cases come, then some preparation is made. Some more cases come, then more preparation is made. So initial preparation is all ad hoc basis and in bits and pieces. Another level of challenge at mental level is at the hospital level. Because of our harsh rules and past history of audit objections, people are afraid to initiate purchase decisions. If you ask somebody to demand purchase, they are afraid that after the pandemic is over, they will be entangled in audit inquiries. Like people are afraid of demanding even a fridge for storing the viral transport media, fearing that they will be entangled in audit inquiries. People are afraid of demanding ventilators, such a important thing during pandemic, but people are afraid of this. So they are afraid that some audit inquiries will be there against them after this pandemic is over. Another challenge is at the mental level. There is a proportionality bias. Generally, bigger problems require bigger solutions. But in case of this pandemic, it's a huge problem, once in a century problem, but the solutions require are small behavioral changes. Don't touch your eyes, don't touch your nose, or don't touch your face without washing hands. But such a small solution for a lay person, it looks like it is not going to be effective. It is difficult to drill that such a huge problem can be solved by small behavioral changes. But these behavioral changes may come, and after some education, repeated education, and making sanitizer and hand washing facilities available, and once social norms are established around these changed behaviors, it will become more and more prevalent. I think that is all I have to say.
Thank you, Dr. Yadav. Probably this was the most lucid narration of the problems from the man in the eye of the storm himself. Let's move on from here, and let me bring on Professor Bob Bollinger. Once again, Professor Bollinger is a professor of medicine as well as public health and also nursing. He's the director of Center for Global Health Education. And I invite Dr. Bollinger to take on the mic, and I am going to give you a presentation rights in a moment, Dr. Bollinger.
Thank you very much.
Yes, we can see your screen now once you share it.
Can you see the slides there?
Yes, absolutely.
Let me just adjust. Okay. So thank you again very much. I was asked, as I said earlier, to talk about some local lessons learned that perhaps might be helpful for others, and particularly in India, as you're thinking about where this epidemic is headed and what your needs and challenges are going to be. So I would focus, and obviously this is a big topic because there have been many lessons learned, but I'm going to focus on a few lessons focused on transmission. Secondly, public health, and then as a clinician, I'll talk a bit about what I think we've learned that might be helpful on the clinical side. So let's start first with transmission lessons. One of the things we've learned here in Maryland in the United States is that early in the epidemic, certainly, much of this new infections were occurring what we call hyper-spreading events. And in our setting, they would be things like nursing homes, prisons, manufacturing, particularly food processing plants where people were in a contained space and working close together, church services, weddings, etc. And also healthcare settings, of course, early in the epidemic. But now what we've learned is as the healthcare system has begun to respond, the healthcare settings are getting safer now. They were not as safe early in the epidemic. So like a lot of places, some of the first people getting infected were unsuspecting healthcare workers who, early in the epidemic, we didn't have testing available. So people were getting exposed both to asymptomatic and symptomatic patients before we knew that this was a COVID epidemic. The other lesson learned, and I think perhaps you're beginning to see this in India as well, is that the profile of infected persons has been changing over time. And I'm going to illustrate locally what that means in Baltimore, and I think it might be helpful in some of your other communities to think about this. So this slide just shows on the left the number of new cases reported per day in my state. And you can see here we are at the end of May, and there's been, there are peaks periodically during the week that are related to delays in reporting to the public health system. But you can see that it's been increasing and it's beginning to flatten out. But frankly, we really have not seen over the last few weeks a decline in new cases. So we're seeing about 1,000 new cases reported every day, and we have for weeks without much evidence that it's declining. However, if you look on the right side, this shows the hospitalization rates. So you can see that we had a big increase in hospitalization rates and now a decline in hospitalization rates. This is the ICU bed requirement, the lower purple bar. This is other acute hospitalizations. And so unlike a lot of my colleagues in India, we're only admitting to the hospital people that are acutely ill. I know in some settings, even mild symptomatic contacts of COVID patients are being hospitalized. But in the United States, we're only admitting people to the hospital who are sick, really sick. And you can see a decline. So why would we see a decline, a big increase in hospitalization and severe illness, and now a decline, and yet at the same time, we're seeing a not much of a change in the reporting of new cases? Well, one reason is because early in the epidemic, certainly here in Maryland and in Europe and other places, the majority of people that were becoming ill were elderly, and many of them were in what we call congregate facility settings, what we call nursing homes, where elderly people were cared for with a lot of chronic illnesses. And over here from our state yesterday, about half of the 2,000 deaths that we've had so far in our state have been in people who were elderly from these nursing home facilities. And that's what's reflected in that really stark increase in hospitalization and deaths early. But over the last few weeks, we're seeing a change in the epidemic. And this is shown here. If you just look here on the right first, you can see that, for example, this large blue bar here, the majority of new cases in the last few weeks have been from Hispanic members of our community. These are people from Latin America, from Mexico, Central America, who are generally younger, who are living in tight controlled settings. They would be equivalent perhaps to some of the settings where your migrant workers live in closed communities with each other. And because that's where the epidemic has now moved from the older nursing home facilities to the community, to specific parts of the community in African American population shown here and in Hispanic population here, we're seeing a change in the epidemic. And we're also seeing that younger people becoming infected, and therefore we're not seeing as much need for hospitalization. But that could change as those same people expose older relatives or older people in the community. And so we could see another peak again of hospitalizations over the next month or so. So let me talk briefly about public health lessons. As I mentioned, elderly people with comorbidities were at greatest risk and continue to be at greatest risk for severe disease. And in general, our lesson has been that the highest risk people actually are more likely to follow guidelines. Our poor and marginalized communities are just not able to follow guidelines because of lack of resources, lack of opportunity. And so that's putting them at greater risk now. And thirdly, I think this is true all over the world. Young people in general are impatient and less likely to follow guidelines. I mean, I've raised 3 children, and I know what that means. They're not good listeners, if you will, at that age. So it's very difficult, and we've seen examples of that not only in our own community but all over the world, where young people were ignoring guidelines to practice physical distancing and masking. And then finally, and this is something Dr. Sharma mentioned, that I think, and I emphasize as well, is without clarity, consistency, and transparency and honesty in communications, we have a problem. And we certainly have a problem here in the United States where our leaders are not being clear and consistent. And therefore, it's no surprise that the community is confused. A good example is illustrated here about masking. We have a big controversy now because our own president refused to wear a mask. People, I don't think, understand why they're supposed to wear a mask. I think we haven't done a good job in communicating clearly, not only from our leaders, but even from our public health officials about some of these public health lessons. And so finally, I'll talk about clinical lessons. I think, and there are many that we've learned. First, and I'll say a little bit more about this in a moment, is around the diagnostics and its role in our clinical management and diagnosis of patients. And there's a lot of discussion around this issue of false negative and false positive nucleic acid tests. And I'm just going to mention some more detail about that briefly in a moment. But I also think, and as I illustrated earlier, another lesson is that the clinical syndrome, how people present clinically, and their risk of progression, as we know, is age and sex dependent. And I think that's why we saw here locally what's happened in Baltimore and in Maryland is that early on there was a lot of morbidity and mortality because the older people with underlying health conditions were getting infected. Now, I wonder, for example, whether you're going to see a reverse of this situation in India, in some communities, where the majority of people who are getting infected now are relatively young. You have a young population. But as those same young people who are relatively well with this disease carry that infection into their homes, into multi-generational families, and into their households, whether you're going to see an increase in serious illness over time as more elderly people or people with underlying conditions become exposed. One interesting thing we've seen here in Baltimore, for example, is that we're seeing a lot of younger people, particularly in the Hispanic and African American community, who are presenting with severe disease. And also in that process of presentation, we're finding very high A1Cs in people that had no idea they had diabetes. So it's uncovering an underlying epidemic of diabetes. And so, for example, in a place like India, where both diabetes and chronic obstructive pulmonary disease are quite prevalent in some populations, you may begin to see as the epidemic moves from relatively young, healthier people into a middle-aged population or people with underlying diabetes risk or COPD, you might in fact see an increase in sicker patients. A related issue is the biphasic illness that we're seeing. Certainly people are presenting, in general, as you've heard, and we're seeing this in Baltimore as well, that they often present with a standard upper respiratory or lower respiratory infection that's probably a viral pneumonia initially. They often get, many of them will feel better after a week or two. They're discharged from the hospital, and then they come back in around day 14 or to 21 with a much more severe immune-mediated inflammatory condition. And that's responsible for a lot of the patients on ventilators now for many, many weeks in our hospitals. And many of them are coming in with what we call asymptomatic hypoxia. They don't feel short of breath, so they don't realize that they're exposing their end organs to hypoxia. And so when they get into the hospital, they're presenting quite ill and quite late with renal failure, cardiac disease, and other complications of asymptomatic hypoxia. And so we're beginning to think about strategies about discharging people with a little more close follow-up, for instance, using home pulse oximeters or portable pulse oximeters in some patients at high risk to try to identify people that are hypoxic and perhaps prevent some of the end organ damage and need for ventilation that we see in the post-inflammatory process. We're having a lot of discussion about clinical management issues. One of the big debates is whether we should be intubating patients earlier or later. And that's still a debate that's going on. In some hospitals up in New York, patients were intubated late, and they had a very, very high mortality. At Hopkins, we've been intubating people a little bit earlier, and we've had a little bit lower mortality. Now, is that because we've intubated a different population of patients or not? We still need to sort that issue out. But a good lesson learned, and this is going to emphasize my final point, is that we learned very early from our colleagues in New York who were facing the epidemic before we were really facing it in Baltimore, that early proning of patients before they needed intubation was quite helpful. And we started implementing that very, very early in Baltimore in our patients. Found a simple intervention like proning patients who were having hypoxia could have a dramatic impact on many of those patients. And so I think these are also lessons learned, that there may be simple steps that sometimes can have a big impact on your management of these patients. Finally, I want to mention treatment. We can say more later if we want about hydroxychloroquine or chloroquine and some of these other suggested treatments. But I, from the very beginning, and I remember getting phone calls and emails from colleagues in India in February asking whether their father or mother should be taking hydroxychloroquine. And I had colleagues, clinicians, doctors who were prescribing themselves hydroxychloroquine, both in the United States and in India, without any evidence that it would work. So I think I would urge us, one of the lessons learned is to make evidence-based decisions. And if there's no evidence, do a randomized controlled trial. And we're certainly seeing, for example, with the new remdesivir data, that a randomized clinical trial is very helpful. And we're also seeing with hydroxychloroquine, a lack of a randomized clinical trial is very unhelpful. And people were exposed to toxic drugs unnecessarily with very little clinical benefit. So I guess the final point again is that it's a lesson learned for all of us is that our local experience can inform our colleagues and friends, and we can inform each other. And so it's important for us all to continue to share information and our lessons learned with our colleagues. This epidemic is not going to wait. We have to be able to share our experiences with each other and help us manage this local problem at a global level. So thank you very much.
Thank you, Professor.
I'm sorry. I think I have one more slide. I just wanted to, I'm sorry. Let me end with this. I did want to mention about diagnosis with nucleic acid. I'm sorry, Ashish. I'm just going to show this last slide. And this is, I borrowed this slide from a colleague of mine, Dr. Natasha Cheetah. So this shows a pooled analysis of the nucleic acid test. And I just want to show, can you see that? I just want to show that, look at this top figure that you'll see here. This is a pooled analysis. And what this shows is the percentage of nucleic acid tests that were negative in patients who have this disease. And you can see here on the far left that at the beginning of, infection, virtually 100% of the tests are negative. But as over a few days and as symptoms progress, of course, the percentage of nucleic acid tests in these patients that are negative declines, as you would expect, as viral load increases. But it never goes to 0. The average is around 25% at the peak time of symptoms around day 5 or 6. And over the subsequent week of symptoms, you can see here, and then it increases again. So if you look out about 2 weeks, 50% of people who've had symptoms for 2 weeks have a negative nucleic acid test. And so the sensitivity of this test for clinical purposes depends a lot on when the patient is tested. So I would just point that out as an example of something we learned early on. So somebody who presents with a classic clinical presentation with a low white count, all the symptoms having a negative test does not mean they don't have COVID infection. And so that was another example of a lesson we've learned that we hopefully will be informative to others. But thank you very much.
Thank you. Thank you, Professor Bollinger. And thank you for sharing your important insights into the clinical management of COVID as well. I invite Amir now to conduct the next poll. We'll have a very quick poll and then we'll go into the next presentation.
Yes, thank you, Dr. Ashish. We are now more than halfway of today's webinar. And the three speakers, Dr. Arun Sharma, Dr. Yadav, and Dr. Bollinger, they have highlighted the important issue of uncovering the many things that have been uncovered during this crisis. Many strengths and weaknesses have been uncovered with regards to leadership, with regards to community level facilities, with regards to our institutional strategies. And I think that is where we need to learn and move ahead. Now we go on for the audience poll, and this is the question that will be there in many of your minds. How will the COVID pandemic end? So let us see what is your opinion about this. Percent have voted, and it's rapidly increasing, marching towards.
I think we could close the poll now.
So I think there is a tough fight between the second and the third position, and here we have the results. The first position is like we will all develop herd immunity, and then second and third position, the people think that a vaccine against this will change the game, and this virus will mutate, shift, and drift away. Antiviral drug, the hope seems to be very less. So over to you, Ashish.
Thank you. So moving ahead from here, I would be calling upon one of my dear colleagues who was at Hopkins while we were together at MPH. And I invite her to introduce Professor Anita Shah before she comes on to speak. Monica Kocher was a dentist in government service, and now she's heading the response of Ayush in the state of Haryana. And I invite Monica to please introduce Dr. Anita Shah. She knows her because she's worked with her so closely.
Thank you, Ashish. Am I audible?
Yes, you are.
Thank you. Thank you, Ashish. It's an honor to introduce Dr. Anita Shah, who has been a constant source of motivation and guidance for not only me, but several other public health candidates at Johns Hopkins. Dr. Anita Shah is a pediatric infectious disease specialist with broad interest in childhood infections in low and middle income group countries, with a specific focus on vaccine preventable infections. Her interest includes clinical epidemiology and immunology of dengue infections in infants and children. She leads a multi-center study on surveillance of invasive pneumococcal infections and clinical pneumonia in children and is evaluating the impact of pneumococcal conjugate vaccine in India. Dr. Shah is presently working as Director Imapact, Johns Hopkins. She also serves on the Council of International Congress of Infectious Diseases and is member of Dengue Vaccines Advisory Committee on Immunization Practice Workshop. She also serves on the NIH Candidate Vaccine Advisory Committee. Dr. Sheth has authored several publications in international journals of high repute. Her work has been well recognized by public health community, and she has been awarded with several awards and honors. I extend a warm welcome to my dear advisor and mentor, Dr. Anita Shah. Over to you, ma'am.
Monica, that was such a nice introduction. I don't think I deserved all that, but thank you so much. It's such a pleasure to be here with you. And again, thanks to Ashish and the faculty at UCMS for this seminar. So I just want, I'll begin. I just want to make sure my screen can be seen. Can you see my slides?
Not yet, not yet.
Sorry about that.
I'll put on your slides. I have them.
Okay. I think I couldn't figure out the icon, but I'm.
Yes. Yes, I put on your slides. You could begin.
Yeah. Okay, excellent. So is it okay if you go
Yes,
to
I
the
will
next slide as I said? Okay, perfect. Thank you. So we can go back to the previous one. So we've heard a lot about COVID, and the topic now that we'll talk about is about immunizations and vaccine preventable diseases. We know that vaccines have made incredible inroads into population health and well-being, and have really saved over 100 million lives. It's hard to count. And they've been one of our most amazing public health tools. And the thing is, sometimes vaccines are victims of their own success, and we often lose sight of the power of vaccines. And I really hope, and I think we all hope, that the current pandemic situation does not make us again see the diseases that really should just be historical. So if you go to the next slide, here's a picture of this really deadly virus. And as I said, we've heard so much about COVID. So this virus is transmitted through the air, spreads through coughing and sneezing. And once a person is infected, the mortality is really high. You know that, right? And the commonest cause of death is pneumonia. So which virus am I talking about? So if you're all thinking of SARS-CoV-2, then that's not the one that I'm talking about. This is measles. We have a really safe and effective vaccine against measles, and we don't want to see measles like we're seeing SARS-CoV-2 right now. Next slide. Now, we've had good success with vaccines overall. Yeah. And in the past few decades, they've really come down dramatically. But not all of the vaccine preventable diseases, the trend is not always downwards, even in the pre-COVID era. And measles is really the classic example. So if you look at the slide here, do you see my arrow? Probably not, right? Yeah, I don't think you can see my arrow, but the picture on the left shows the trend of measles over the decades, and you can see that the cases of measles decreased dramatically between 1980 and 2010s. But in 2018, the number of cases surged, and there were an estimated 10 million cases worldwide, with over 140,000 measles deaths, really preventable deaths. And this is like a 50% increase since 2016. So that is quite dramatic. On the right side, there's a map, and it shows countries where there have been really a huge outbreak of measles over the past 3 to 4 years. The Philippines, Madagascar, Ukraine, and the DRC. But following behind, sadly, is India, which is not shown in the map, but India also reported about 70 to 80,000 cases in 2018 and 19. So this is something to keep in the background as we go forward and look at the situation now. But next slide. Thank you. So before we go forward into the COVID era, I want to talk about some of the lessons that we can learn in the recent past. And this is the Ebola virus outbreak in West Africa in 2014. And this primarily took place in Guinea, in Liberia, and Sierra Leone. And together they reported over 11,000 deaths due to Ebola. But the impact is really much more than Ebola if you look at the indirect effects. So there was a shifting of health resources to the Ebola response and breakdown of healthcare systems and stigma due to disease. And this is not unlike what we're seeing now in COVID. And there was also reduced vaccination and all these subsequent negative effects, particularly on maternal and child health, because mothers and children are often the most vulnerable people in society. And this table here actually shows some of the studies that report reduced antenatal visits and decreased child outpatient visits and decrease in vaccination. So these were actually reported events. And there was a group of scientists from Johns Hopkins who published a paper in Science that estimated that there could be over 1.5 million children in those 3 countries alone that would remain unvaccinated over a period of 18 months just during the Ebola outbreak and all the disruptions that were caused by that outbreak, resulting in over 20,000 deaths, as shown in the last row of this table. So this can be really dramatic if you translate that into the current period. Next slide. So recently, the World Health Organization and UNICEF did this worldwide poll or survey from different countries to look at what is the status of immunization services in the months of March and April. And here is a slide that was taken from a presentation that was made by Anne Lindstrand, who's the head of EPI at the WHO, recently in another seminar that she gave. And this shows the countries, so this is a world map which shows most of the countries that reported. The countries in red, orange, and yellow show some level of disruption, either total suspension or partial disruption of immunization services. So these are routine services given in clinics as well as outreach. So you can see how widespread the problem is just in the last 2 months. Next slide. So we also had the opportunity, our group at Imapact, to work with the WHO and look at these specific places and see what the actual effects are. And we found that there could be over 80 million children who are under 1 year of age who could be at risk for vaccine preventable disease due to these disruptions in these different areas. And when you classify the level of disruption, whether it's complete, whether it's both fixed and routine immunization services and outreach, the number of children facing severe disruption would be about 71 million. So it's really huge, and it's just been 2 months. Right? So again, there's a lot we don't know. So as we go forward, we will have to see what the actual effects would be of these levels of disruption. Next slide. One of the earliest casualties of all the disruptions and the lockdowns that have been happening everywhere are the campaign services. So they play a very important role in trying to reduce the last few pockets. And 2 big campaigns are the polio campaign and the measles and rubella campaigns. So the polio eradication campaign actually quite early on made this really painful decision of stopping their campaign services to reduce the risk to their workers and also to actually help countries. They shifted their workers to the COVID response because that was very important at that time. Although they tried to maintain at least surveillance because that was important to know. And this map on the left side is taken from the Global Polio Eradication Initiative, and the URL is down there as well if you want to check. And they do a real-time mapping of the cases of wild polio that's happening in different parts of the world. And what really struck me is if you look at the blue numbers represent the cases of wild paralytic polio that have been reported. And the cases reported from January 1st to May 27th of this year is 58. And the number of cases reported last year in the same period is 37. So this makes me nervous because it's just beginning and we are already seeing this increase of polio. So it's just such a ominous harbinger of what can come in the future because of these disruptions. And the map on the right is another similar map that shows globally about the measles rubella campaigns. And the colors represent the density or the burden of measles in different parts of the world. And the countries that are colored in blue and yellow are the ones that are reporting disruptions of these campaigns. So again, it's just the first few months and we have to really keep antennae up about what's happening with these conditions and the surveillance to know what's really going to be the impact going forward. Next slide. So that was a global picture. Now in India, so India too is not very different, right? You know, you talked about the lockdown and the effects and all the direct and the indirect effects. So just focusing on immunization, we did an online survey that we sent around to pediatricians and primary healthcare providers in India through the Indian Academy of Pediatrics and the Maternal and Child Health Center in Kolkata. So they reached out to about 400 to 500 pediatricians who responded. And this is what we found. This is just preliminary data. And it looks like vaccination services have been suspended in most places. So most of the people who responded, so about over 80%, said that these services were suspended, both in the private and in the public sector. And some clinics did remain open and there were partial services continuing, but they reported that the numbers of children seen had dropped substantially. So over half of them said that their numbers dropped to about 20 to 10% of what they had been seeing earlier. So that's quite dramatic. And it's not surprising because we know that India is in the lockdown period and there's obviously decreased uptake of service as well. And the reasons would be fear among the public and also the travel restrictions. Healthcare workers are also impacted. And there are changing health priorities because, of course, now COVID is now top priority. But it's just something for us to keep in mind that as we move on and we get more used to dealing with COVID, that we can't lose sight of these other really, really dangerous conditions as well. And many of these physicians and health workers came up with excellent suggestions as to what are the mitigation steps to be implemented in the near future. And some of the options that I've just put down here would be extended clinic hours, use of social distancing in more innovative ways. Also, door-to-door and outreach services should be expanded, is what many people recommended. And a very important thing, a theme that kept coming up was about community awareness. And I know that Dr. Arun Sharma had also mentioned that, as well as Bob Bollinger, that it's so important for the public to understand what's going on and what are the current levels of cases and the advances that we have in the medical and public health era, and also engagement of the public. That's so important. And then the other important theme that came up is to really bring people together to have more public-private partnerships and work together and increase collaborations to implement these services. Next slide. And is that the last one? I think it's one, yeah. So this is a slide I just put up because this is the interim guidance that the WHO put out very early in 26th March. And then subsequently, they also published some FAQs, and both the links are provided below. So they provide some general guiding principles about what can we do about immunization. And an important thing to reinforce that all governments have to propagate is that immunization is a core health service that should absolutely be prioritized. And at the same time, protecting the healthcare workers is critical. So much has changed in terms of our infection control practices in general clinics, use of PPEs. So all those things have to be brought into play. And then, of course, there's a convenience factor and a cost factor. So those are very important for local policies to revise and to review and also implement. And then the third bullet point is about vaccine preventable disease surveillance and how that should be maintained. Because in the most recent poll, we're also hearing that the surveillance mechanism is also being disrupted. And that can be dangerous if we completely fly blind and we don't know what's going on in terms of what the increase or decrease of diseases would be. And then countries should plan right away to design strategies for catch-up vaccinations, because that's critical. If you unimmunize a cohort of children, or you don't immunize a cohort of children for about 2 to 4 months, then if you are able to catch up at least half of them, you've done a good degree of mitigation. So that's really important to put in place. And their guidelines also focus on reinstating the routine immunizations and catching up, as we just mentioned, and also planning for mass campaigns again to restart. So that's my last slide, and I just wanted to end to say that many countries are taking these guidelines and trying to adapt it to local contexts and try and implement it. But it's a slow process because there are so many priorities now, and it's just important for everyone, for the healthcare people and policymakers and for the public to understand the importance of this, because it's just something we can't afford to forget, even as we are dealing with COVID. So thank you. I'll just stop there and take questions later.
Thank you, Dr. Sheth, and thank you for that wonderful eye-opener into what we might be looking at and what might be happening soon. Let me bring in Dr. Bollinger here, who is just about to leave because he's got another hard meeting next happening in another few minutes. Dr. Bollinger, why don't you say a final comment and your final goodbye?
Well, thank you again, everyone, and thank you for the wonderful opportunity to learn from all of you and participate in this webinar. I think we've all reinforced the same message that there are lessons learned and challenges that all of us are going to face both locally and globally, and it's sessions like this that allow us to share those lessons learned with each other and hopefully find ways to manage overcoming some of these important challenges together. I'm sorry I have to leave, but I want to thank and congratulate all the other speakers because I've certainly learned a lot from all of you, and I look forward to engaging with all of you again in the future. Thank you.
Thank you. Dr. Anita, would you be staying over for some more time? I do understand you have another meeting in another few minutes, but we have the last speaker coming in next.
I can stay.
Thank
no
you.
problem.
Amir, I would like you to. Amir, I would invite you to introduce the next speaker.
Yes. So thank you, Dr. Anita Shah. This to succinctly focus on the vaccine preventable diseases, how they are just waiting to come back and attack us because of all this breakdown that has happened in routine vaccinations. And now we move on to the next session is on the wait for a vaccine. If we look at the polls that we held just now, that poll said that in terms of herd immunity, that is a natural way in which this thing will go end. Otherwise, it is the vaccine. If we talk about some artificial intervention, some human intervention that can end the pandemic, most people have high hopes from a vaccine, and day in and day out we hear about in various sources that today this vaccine is coming out, tomorrow that vaccine is coming out, but nothing is actually coming out. So here we have Dr. Shukla Das, an eminent microbiologist, and I would just like to quickly introduce her. There are many things in her introduction. One is that she is an expert in bioaerosol monitoring, and that is very pertinent to the topic that we are dealing with today. Other than that, immunology, specifically in autoimmune skin diseases, allergic fungal infections. She has got many publications, many funded projects. She is doing a lot, and here she is today here to talk about the wait for a vaccine. And let us hear from Dr. Shukla Das now. Dr. Shukla Das, ma'am,
Okay, 1 minute.
can you?
Yeah, can you hear me now?
Yes, we can.
Yeah, thank you so much. So thanks for the introduction. So I want to say a word where Dr. Anita left, that definitely we are so overwhelmed with COVID-19 at the moment that there have been, in fact, I went through a few outbreaks, and you know, there was in May, measles outbreak has been reported in US, and a meningococcal disease in children has been, meningitis has been reported in Burkina Faso, and even yellow fever. So I'm sure she has pointed out a very important issue, that if we neglect the regular immunization program, we will be landing up with more and more of outbreaks of the ones which are preventable. So I go back to this wait for a vaccine. We have waited for quite some time now. So I'll make it a little brief. But before I go on to COVID, I just want to, you know, introduce the audience to this virus. This respiratory viruses, we all know, we are all accustomed to these various respiratory viruses which are circulating globally. And one of them, which I want to set an example before I go on to coronavirus, is that influenza H1N1. We cannot forget the last pandemic in 2009, and that was a pandemic which took thousands of lives in 2009, and now it is of course a regular part of the annual flu season. But epidemiological pattern, if we see that whenever there is a first wave of infection, we build up an immunity and we kick out the virus, and later when the immunity falls, the virus does come back. Now at that time with the influenza, we have several vaccines circulating, H3N2, and there are various variants of influenza. Now, to remember, when pandemic 2009 H1N1 hit, there was a scare, and there was a lookout for a vaccine which could only hit H1N1. So what the researchers did was to you know, switch over to a monovalent vaccine. And by the time the researchers could build up a vaccine, it was 2013, and the pandemic hit again. Now we decided that rather they will include all the variants and have a vaccine which is trivalent or a tetravalent vaccine, and which can include all of them. So you see, vaccine is promising, is the answer to these ever-changing genetic diverse viral infection, but is it so easy? Let's go back to in fact, we must remember the 2016, 2018, 2019, we had terrible outbreaks of H1N1 from south of India, southern parts of India, and they have taken a lot of lives. So we are dealing in these viral infections in and out, and now there is the virus this we are facing, it is certainly novel, and there are fatalities, and we cannot fathom the outcome of this disease. So till now, coronavirus, we do not have a vaccine. And there were earlier, the scientists did work upon SARS and MERS, but it died a natural death. Now, vaccine is a simple solution, but to have a robust immunity, build up a robust immunity in this population, is it so easy? It cannot be achieved so fast. Now, the good thing about coronavirus is that the genome is already out. And there is a lot of literature which says that the S protein and the RBD, that is the receptor binding protein, is one of the dynamic proteins where vaccines, and there are various platforms of vaccine technologies are being used. Various countries are into it to build up a vaccine. However, we need to understand that the virus is mutating. This also has been published, And there are various points like the spike protein, the non-structural protein, and some of the RBD proteins also are showing some mutation. So then if we build up a vaccine, will we have, we have to take care of these escape mutants and again a fall in immunity. Now let us take a situation where we do not have a vaccine, like the poll also included herd immunity. If suppose we, suggest or we consider that this virus is here to stay with us and it becomes endemic, we get seasonal outbreaks. So yes, in this situation, we require a vaccine, a lifelong vaccine. However, if suppose we allow this virus to build up a herd immunity in this entire 1.3 billion population, then also we need to stay with this coronavirus, and it's going to take some time. And let us remember, it is a novel virus. The fatalities will keep coming. So as it was mentioned by Dr. Anil Yadav, we need to keep up, the case critical care facilities should be upgraded, and all the guidelines which we have been following, rather whether we have a vaccine or not, that social distancing, reappropriating the treatment, look at the treatment modalities of each case, these should be kept in mind always and be on the alert. Now, sometimes we feel there are cross immunity because of so many respiratory viruses. We may be having heterologous immunity. Even that will be short-lived. So overall, and if we allow this pandemic to peak, it hasn't reached a peak, but let it fall down, do we think that we are going to be safe? No, I don't think so. The immunity, we really do not have hard data on the antibody responses, and we really do not know whether we will be reinfected again. I feel that another outbreak will be inevitable. Now let us see, if we really want to make a vaccine, all right, do we look for a heterologous immunity? What do we understand? Let's see, we have spillovers from so many animal coronaviruses, the civet, raccoons, and monkey, camel, everywhere. Should we have an immunity which will cover all the beta corona lineages? Yes, one time if you want to prepare a vaccine, let's have one vaccine which can take care of all these coronavirus lineages. But to create a heterologous immunity, we will have a large number of epitopes have to be addressed. And that heterologous kind of immunity can be dangerous at a time. Sometimes these non-neutralizing antibodies can create ADE, which we learned, which I think most of you know, antibody-dependent enhancement, like we see in dengue. We have all the 4 serotypes, but then we come up with hemorrhagic shocks because some other serotype in presence of a neutralizing antibody creates a fatal situation. Now, so we come to a platform where we need a vaccine. So let us think, what do we need? Do we need a very robust vaccine for the naive population? And say, let's go back to the era of Jenna, that we can take up the example of OPV, a live attenuated vaccine. Yes, that will be good because it will build up a mucosal, a humoral, cell-mediated, everything, systemic immunity. That is what we are looking for. It will prime the immune responses, and naive population will be happy. But that's going to take some time. Live attenuated virus vaccines, it does take some time, and safety concerns are a big issue. Right now, what we would prefer is to prevent the disease, reduce the shedding of the virus, and produce a sterilizing immunity. And that also to the targeted vulnerable population. Whom do we think right now are the vulnerable population? The vulnerable population should be the ones who are working upfront. These are the healthcare workers, the elderlies, the immunocompromised. If we go on to cover these first and then build up another live attenuated vaccine, we will do the the naive population can be immunized later on. So having said that, there are a lot of companies which are working upon the vaccine, and the current vaccine which is gone into phase 2 and phase 3 trial is a Moderna vaccine. That's an mRNA vaccine, and it is very well addressing the spike protein, and they have found very good neutralizing antibody response. Now, one concern here is the animal experiments are showing protection, but the sterilizing immunity is not long lasting. Now, one word, the challenge that we will face here is definitely whether this will produce a long lasting immunity. We do not know that. However, there are certain Indian Bharat Biotech and Serum Institute are very optimistic and trying to build up with partnership with US. They are going to bring us with a vaccine by October 2020, so one does not know. And Now I would like to add a little bit, a paragraph, maybe a few thoughts for the audience to understand. We Indians, with a unique microbiome and an environment of parasites and fungal pathogens all around us, we definitely must be triggering our bystander B and T cells. So probably there is a heterologous immunity which we are building up. That's why we are seeing 80% of our patients to be asymptomatic or probably milder symptoms. Another paper or hypothesis that has come up, which probably is very interesting, is the BCG vaccination. There are BCG vaccinated countries like Japan, India, and Korea. They have reported lesser number of cases compared to Italy and US, where BCG vaccine not used. So this is like an epigenetic reprogramming. We are rewiring our immune system, the B and the T cells, and probably these are having a role to play and having a kind of a non-specific immunity and reduce the severity of the infections in our community is probably a little less. So having said that, we have to learn. I would end this session by saying that we need to live with the virus rather than waiting for a vaccine. Let us work upon repurposing the drugs. These are faster. We can use them rather than a vaccine. We may have an antiviral. We may use plasma therapy is already being used. We may have an antibody treatment and improve the critical care facility has already been said, and so that we aim that the hospitalization can be reduced to 50%. Probably that would take us a long way ahead, and we will be able to survive in this era of pandemic. Thank you. That's all, Dr. Ashish, I had to say.
Thank you, Dr. Shukla Das. Amir, would you like to take over?
I think we are at the end of the sessions now. So I think we are already past the time that was scheduled. So what do you suggest, Ashish? Should we go for some question answers?
I don't see anybody in the audience having raised their hands or presented with a question. So I think we should just close with the final remarks.
So the final remarks, Dr. Robert Bollinger has left. He has already said his concluding remarks. I would like Dr. Anita Shah to please tell her concluding remarks for the session, please. Dr. Anita
Thank
Shah.
you again. Yeah, thank you. I think the panelists have just been really brilliant in bringing out the different issues and interfacing all the complexities that we're facing right now. And I talked about the indirect effects, but there are so many different facets of that, of the indirect effects as well, that have been brought out. And also the hope for a new vaccine and the caveats associated with that. So I think I don't have very much more to add other than to say that this is a space to be watched out for, and it's to be continued. And it's important again to remember that it just needs everyone to work together on it. It's just not something that one individual country or group or institution can work alone with. So thank you again for bringing us together for this webinar.
Thank you, ma'am, for your message. Dr. Anil Yadav, can you hear me? Dr. Anil Yadav?
Dr. Yadav, your mic is unmuted if you would like to put in some concluding remarks, or maybe he's just got busy with some other call from the local problem, which
he is very busy
solving one of them. He's completely in the eye of the storm at this time, and he's at a very, very unenviable.
Minute-to-minute decisions and actions have to be taken. So I would just ask Dr. Shukla Das for a concluding remark, please. Dr. Shukla Das?
Okay, yeah. So, this was very well conducted. And to conclude, my remarks would be that yes, we will all eagerly be waiting for a vaccine. But meanwhile, let's not get complacent. And we have a lot of therapies that are going on. Dr. Ashish had asked me to look through a lot of literature in leading to plasma therapy and all. We are moving forwards to bring down the fatalities and repurposing the drugs. Probably that is where we need to get our intelligence working and reduce these fatalities and make these segregate these patients into mild, moderate, and severe, and probably that will be helping us to bring down the pandemic to a decline. Thank you.
Thank you, ma'am. Thank you very much. Dr. Arun Sharma, sir, your concluding remark, please.
Thank you, Amir. I think everything has been discussed in quite detail, and all I can say is that from the community impact point of view, yes, mitigation is possible, but we need to make concerted efforts, everyone, so that we reach the last man standing with the right communication, the right picture, and the clear scenario, what are the do's and don'ts, and how he can participate. As community medicine people, our responsibilities are more, and I think we have to make further efforts to make sure that the community participation helps us win this fight over COVID-19. Thank you.
Can I speak
Thank
now?
you, sir.
Can I speak?
Dr. Anil Yadav. Yes, sir.
Yeah,
Please,
I
sir.
want
We
to
are
make my
waiting for
final
you.
comment.
Yes, sir.
Can I speak now?
Yes, sir.
Yeah,
You can speak, please.
Yeah, I'm an optimist, and I think this virus is here to teach us something, and it teaching us how to behave. And I think by adopting these behaviors in the long term, my hope is that we will be able to avoid as many deaths as it is causing, by avoiding other deaths in future by influenza, H1N1, tuberculosis. My hope is that we will be able to prevent at least as many deaths as COVID is causing in these years. That is all. Thank you so much. Thank you.
Thank you very much, sir. Very pertinent remark and being optimistic.
Thank you.
So I had the concluding remarks. So before I move on to Dr. Ashish, I would like to, because I would like to save the man behind the whole show for the last comment. This pandemic has uncovered both the strengths and limitations that of the humanity, whole humanity in this century, and we have to see to it that we don't hide our limitations once again, as it has come up front now. We should tackle each one by one, and the strengths that have come up, that has been brought out, whether it is about human endurance, whether it is about local leadership and other innovative strategies, we have to reward them and we have to take them forward. So that is my message, and thank you, Dr. Ashish, for this opportunity and this coming together of national and international faculty to collaborate on this. Dr. Ashish, your final concluding remarks, the man behind the show.
Thank you so much. There is nothing much that I would like to say. I hope that this is a beginning and we would be able to collaborate further and work on more projects and events and organizations together. Thank you, everyone, and thank you for joining in.
Bye.